Hello, everyone. My name is Christa Studzinski. I'm the Director of Business Development and Partnerships at the Ontario Brain Institute. I'll be your moderator for this year's installment of the OBI Power Hour, Empowering Seniors to Defy Dementia with Neurotech. Thank you for joining us this afternoon for an amazing all-female panel. I'm honored to be sharing the virtual stage with these incredible women. We hope to get your synapses firing. We'll have about 50 minutes today with Catherine, Lia, and Shawn. We'll also be available on the chat while you're watching the video to answer any questions that you may have. Before I introduce our first panelist, a quick note about the Ontario Brain Institute. We are a provincially funded not-for-profit with a vision to improve the brain health of Ontarians. We partner across the brain health ecosystem to accelerate discovery and get it out into the community where people are living with and receiving care for their brain disorders. Today's panel will feature OBI's newest program called Cortex. Cortex is a program that partners community groups with startups to get neurotech into the hands of seniors so they can tell us how it works in the real world where life is just a little bit more complex. Each project compares the neurotech to a clinically relevant scale that is administered by a community partner. We can then match the neurotech data and the community data through BrainCode, our informatics platform. This minimizes the amount of identifying information that's shared with the company while also allowing us to measure how the device works out in the real world, out in the wild. We've done 9 of these projects so far, and as a result, we've been able to provide access to neurotech to over 1,300 individuals, many of them seniors. Catherine and Lia will highlight the outcomes from 2 Cortex projects that we discussed at last year's CAPI Summit. Shawn will share details about the newest Cortex initiative, and then we'll bring everyone together for a more interactive discussion about neurotech testing in the community. Without further ado, please welcome Catherine Bornbaum, Chief Business Officer at Retispec, to tell us about their recently completed Cortex project.
It's a pleasure to be here to share a little bit about some of our exciting work together. So I'm from a company called Retispec, and we are on a mission to enable widespread early and accurate detection of neurodegenerative disease markers in a way that's accessible, affordable, and scalable using AI-driven retinal imaging. And just for a little bit of context about the opportunity that we undertook together, this was an initiative that was supported in part by the Davos Alzheimer's Collaborative, which is leading the largest global response to Alzheimer's disease. And so they recognize that health systems around the world are not at all prepared for the world where we have disease-modifying therapeutics available for Alzheimer's disease. And so they wanted to provide an opportunity for community-based initiatives, which aligns very well with our work through the Ontario Brain Institute. And so they put out a call for proposals that were novel. And so Retispec was very fortunate to partner up with a number of groups here in Ontario, including the Ontario Brain Institute, the Centre for Aging and Brain Health Innovation, along with the Alzheimer Society of Toronto and Ontario, and others, as you'll see in the bottom of the screen here. And we were really focused on enabling opportunities for folks to have a cognitive assessment and also a Retispec scan in the community. And so we really wanted this to be accessible, to be comfortable, and to be in places that were very familiar. And so I'll just jump back here. We set a few project objectives for this. And so we wanted to leverage these community-based settings in order to increase rates of cognitive assessments that were performed on adults 65 and older who have memory complaints. And so some of these areas, the age and the fact that folks have memory complaints, were determined by the Davos Alzheimer's Collaborative. But we actually found as we embarked on this project that the demand for assessments actually started much earlier than age 65. And so collectively, we decided to make an adjustment to this. And we actually lowered our age to 55. We also wanted to increase awareness of brain health for adults with memory complaints in non-traditional settings. And so for part of this initiative, we actually did the Retispec screening in optometry settings. And this really allowed us to provide a new venue for access into these assessments. And really, we wanted to see if this would help with some of the stigma that we were seeing around Alzheimer's disease and memory concerns. Finally, since what we were doing is a bit novel, we wanted to assess the risks, benefits, facilitators, and barriers to working in these community-based settings as a means of sustainable health system access points in order to increase the rates of assessments. Okay, and so what this actually looked like in reality was that we did conduct our assessments, and these assessments were completed largely by the Alzheimer Society of Toronto for the cognitive assessments and by optometry settings for the Retispec assessments. And we had people could enter the screening program in either venue. So there were a number of community based screening access points by the Alzheimer Society of Toronto. And they actually did a few pop up clinics as well to really make sure that the reach was available. And we started out with just one optometry clinic at the beginning of this program, but we found that the demand was sufficient. And so we actually expanded out and added a second one within our time frame. And then we were really curious to see what happened afterwards. So, did people actually connect with a primary care provider? Did they receive specialty care if that was warranted? And did they go on to actually receive a diagnosis or any follow on care or services? And what we learned is that community based settings were incredibly important in terms of being able to identify the signs early and to facilitate early detection. So, from the optometry perspective, we really didn't know what would happen. So, we hoped that it would be helpful, but we really didn't know. And what we found was that despite the program running for just a handful of months, because this was a time limited project, we had very, very high demand, and we had a number of folks, nearly 1,000, who went through the preliminary screening. We also saw that this approach really allowed us to reach a very diverse set of individuals relative to their race and ethnicity, which sometimes is missing in other screening programs. So I think being in the community and having trusted providers really helped enable the reach and access of this type of program. And from the Retispec side of things, this particular test was quite quick and simple. So the whole process takes about 10 minutes from that side. And then the cognitive assessments were also rather efficient and done by qualified and trained social workers. So we really wanted to ensure that this was a high quality experience for the participants. A little bit more on the scan, just because this is quite novel side of things. We actually asked folks to complete a survey about 24 hours after completing the scan, just so they had some time to reflect on it and think about what that experience was like for them. And we found that overall, people found the experience to be very comfortable and simple, and that they'd be interested in having this type of technology should it be approved by regulatory authorities. We also heard some feedback from participants that tells us that there's a really strong interest in having information about your health, and that they really, really care about understanding where they are in terms of the cognitive assessments, in terms of the Retispec score. They wanted as much information as was available to them. A couple other exciting aspects from this study. We were fortunate to have the opportunity to engage with some members of the provincial government as they were working towards the Improving Dementia Care in Ontario Act. And so I think above and beyond some of the actual on the ground activities that we had, such as expanding our footprint to a new site, expanding the reach of this program by lowering the age of eligibility, and by getting really directly out into the community by having a number of pop-up clinics, we really saw the full circle impact by obtaining the attention of the government about the importance of early detection and ensuring appropriate care downstream from that. Just a few lessons that we learned through this process. First and foremost, that stigma around Alzheimer's disease and memory concerns remains a very persistent consideration. We also saw that how a screening program is introduced can actually impact an individual's willingness to take part. And this makes us really need to consider sort of the language that we use, who is providing the screening, what qualifications they have, and how sort of comfortable they are in this landscape. It's really important that the folks doing this be trained properly and be very comfortable working in the space. We saw that the involvement of a nurse practitioner really helped to close care gaps. So in our case, one of the things that was very interesting to hear from the participants was that they often had already reported their concerns about their memory to a primary care provider, but that it was attributed to normal, healthy aging, though it didn't feel normal to them. And that's part of why they were interested in this screening program. And so we felt that it was really helpful to have this extra qualified nurse practitioner who was a part of our community-based program, where she could be sort of a stopgap. And so if they didn't get the care or the sort of recognition of their concerns at the first level, then we did have a backup in order to ensure that someone could have a conversation with a qualified professional about next steps. And for some cases, folks didn't have a primary care provider. And so this nurse practitioner closed that gap for them as well. So overall, we had really, really strong feedback around this. And lastly, we were thrilled to learn that optometry was actually a very useful venue for screening. I mentioned earlier, we didn't really know what would happen in this case. We were hopeful, but we did find that the optometrists were very knowledgeable. They're excellent healthcare providers, and they actually look into signs of brain health every day in their practices. Because of the connection between the eye and the brain, they're already looking for signs of brain tumors or strokes or things like that. And so this was just an extension to the type of care that they already provide. They may just not talk about it too much. And they also directly connect into primary care routinely because of detection of things like diabetic retinopathy. So we were really sort of surprised and excited to see that this venue may provide a very useful way to expand the reach and hopefully to help destigmatize early detection of Alzheimer's disease. So I'll just pause there, but I'm happy to elaborate on anything else as we continue the conversation.
Amazing. Thank you so much, Catherine. What an incredible project. Congratulations to you and the teams. It was an honor to be able to play a small role on this. The traction that you have seen from the seniors in terms of volunteering for this project was just incredible. And we'll put a pin in that and come back to it in the panel discussion. But next up, we have Lia, Executive Director of the Sheridan Centre for Elder Research. And she's going to talk about a Cortex project that we are just in the process of wrapping up. Lia.
Hello. And thank you, Catherine, also for setting the stage so well for the things I'm about to talk about, because there are so many parallels. So I'm going to share a similar example from our center of a way that we acted as the community hub for neurotech testing. So almost analogous to the optometry clinics that Catherine was referencing. We played the community outreach role in this particular instance. A little bit about us first. We're based out of Sheridan College in Oakville, Ontario. We've been around for 20 years now, and our mandate for that entire time has been really dual in nature. It's been to conduct high quality applied research that supports older adults and their health and well-being and all of those who work and engage and support them. But we also really take to heart our role as serving as an education resource hub for Sheridan and the broader community. And to me, this speaks to exactly the reason that we engage with groups like OBI and others to deploy technologies to test programs and services and evaluate them, because it's all well and good for all of us to be doing research locked in our silos or in our little isolated communities, but we really have to get all of these technologies and these offerings into the hands of clinicians and members of the public so we can see how they work in real life. Most of the time, the way that our projects unfold are really a combination of the right partners, the real world questions, issues, challenges, opportunities, and then what we can bring from Sheridan's expertise kind of capacity. And a long time ago, the founding director of the center trademarked the phrase lab to life, which is really how we approach all of these things, right? How are we taking what's been developed in a lab and translating it into a way where we can evaluate it in its real life type of context? In this particular question, or project rather, the question we were answering was really to ask, can sophisticated technologies that can be accessed and analyzed entirely remotely, so without necessarily needing a patient or participant to engage physically in real time with a clinician, can this offer a mechanism to monitor cognition and mental health and potentially support the early identification of clinically meaningful changes in either cognition or mental health status? So, a couple of sub-questions and objectives, do the data that we collect through these technologies, do they match the validity of traditional data collection approaches? So if I, as a patient, am sharing information entirely remotely with one of these technologies, are we confident that the data collection matches what one would be receiving clinically as traditionally they might? Is this model feasible, scalable, and implementable in a variety of environments and contexts? So as you'll see, we were conducting it in our lab. So we were the remote location because this is still early stages of this particular project and its implementation. But the ultimate goal was to see how might this be scalable if you were in your own home, in a rural community, traveling anywhere around the world. Can this work? And then perhaps most importantly is, do the participants like it? And we will see that part of it involves talking to a virtual human, and so liking it is a really important piece of the puzzle. So we combined two technologies through this project, one by Winterlight Labs and one from a company called Soul Machines based out of New Zealand. So with Winterlight Labs, what they're able to do is they're able to take short snippets of speech, conversational speech. They can analyze it and detect digital biomarkers that may identify cognitive impairment or cognitive changes that may be associated with either dementia or mental illness or both. Soul machines use virtual human characters that can engage in conversation and in some cases can respond in real time to visual and auditory signals coming from the user. So when I say visual and auditory signals, I mean speech, but I also mean gesture. And there's to a limited extent facial expression and emotion as it might be present on my face. So we combine these two. And so our task was really that a participant would come in, speak to a virtual human named Sam, which you'll get to see in the next slide, tell Sam a story, tell Sam about the last 2 weeks. Winterlight is capturing those auditory data on the back end, and then both companies are using their own respective analytic platforms to interpret what they've seen from a visual and auditory standpoint about this particular person. Collect some baseline data and then see how that may change over the course of a year. In this project, the way that we structured it was we had folks come back every 2 to 3 months for repeated sessions, and we completed all the same measurement tools, both the gold standard ones as well as the ones within both of these companies' algorithms, so that by the end of it, we get to a point where we have, we do have some longitudinal data about all of these individuals and their speech patterns, and we can sort of see how does everything match up and how did this work as a year-long sort of remote clinical exploratory type of project. This has a video here, which I'm hopeful will play in this context, but if it doesn't, what we're seeing here is we see one of our older participants who is speaking with Sam here on the computer. They're about to have a conversation. Sam is about to tell this participant that they've got to tell Sam what they're seeing in this image that is presented on the screen. That's a task that is used through the Winterlight algorithm. Respond to a visual picture, describe it in your own words. And as you may see, this participant has a bit of a kick out of it because the picture is slightly comical. And so now I'll play the video and we'll see if this tracks.
Task. For this task, I will show you an image on screen, and I will ask you to describe everything that you see in the picture. Here is the image that I would like you to describe. Please tell me everything that you see in the picture. Let the researcher know once you have finished your answer.
Okay. I see an aging couple in their living room, and he is standing on a chair, which isn't the safest thing to do, to change a light bulb. I would probably stand on chairs too, but I can appreciate it's not safe. They have at least moved the coffee table out of the way so that he has access to the light. She's probably telling him how to do it because that's what she could do. And the cat is chasing.
So, I enjoy this video just because it's really comical that she's clearly judging the couple and the way that they're going about changing the light bulb here. But as you notice at the end, she said, I am finished. And that's the cue to the virtual human to sort of close the task and sort of stop that recording of that particular audio snippet. But so that would be one example of how someone would be engaging in this task when they come into our lab. And this is sort of simulating a community-based deployment, perhaps in a public space like an internet cafe or a library or a clinic, for example, or ultimately if you could do this from your own home computer at any given time. So in the end, how did it all go? Well, in general, participants enjoyed engaging with the virtual human and completing the assessments. They thought it was fun. Sam was kind of neat. They had a lot of the usual feedback about virtual or artificial characters and that they don't always look you quite in the eyes and they're not always, responding to the right thing. But on the whole, they kind of enjoyed that whole process. One of the most interesting pieces of feedback, though, was around how the virtual human character might be tailored to better support this entire process, specifically as it relates to cognition and mental health. Might people feel more comfortable talking about their mental health to someone who's an age-matched peer or a culture-matched peer, for example? There was a lot of dialogue from our participants about what they would want their virtual clinician to look like. And I think that's a really fascinating element that I don't know that we had necessarily predicted coming out of this is, it gives people the opportunity to create a context where they feel comfortable talking about their health and well-being, particularly mental health. So that was a really interesting angle around, the visual and the engagement with the character. There's a lot of evidence that this can be a very valuable approach for a lot of contexts, including remote and rural delivery. But there are indeed a number of caveats. Tech glitches happened. They need full-time monitoring on the back end. So it's not necessarily just a set it and forget it kind of a program. The technology providers definitely need to be engaged in that whole process as it intersects with any clinical engagement or feedback to clinical partners. The potential mental health implications need to be very fully considered. We were very mindful at the outset of this study about recruitment and not recruiting individuals who had either any sort of undiagnosed was a little more difficult, but unmonitored mental health conditions or challenges. So we tried to ask a lot of questions, while not invasive, but gave us a lot of confidence in that folks were not coming into having a dialogue with a virtual human character that may be in any way triggering or discouraging or damaging to them, because we're not in a position to be providing the relevant clinical support, right? So it's different than Catherine's example, where they're within a clinical setting. Because this was a research-based community setting, we didn't have that. So we were really mindful of that. And that's a really important piece of feedback for any remote delivery. You don't want someone who's stuck in a rural county in the middle of a snowstorm pouring out their heart to a virtual human who then has no recourse about anything that they've said. So that's a really important consideration, certainly. And, of course, just like everything, people forget. People book travel. People do all sorts of things, and they may lose track of their appointments. And so a way to support completion, so automated reminders, that type of thing, would be really important to bake into the delivery of this. And we're not quite done all the analysis yet, so validity data are still to come, and maybe we can update you on that next year in the Power Hour. At the end of the day, though, what I think this all means for all of us here in the panel and for this project in particular is that I think we're breaking new ground in the way that we think about how people can monitor their own brain health. I mean, Catherine referenced that people want to know about their own health, and they want that information about themselves. And I think we have new ways of getting the information and getting it to people than we ever did before. And so I think it's a really exciting time for neurotech in general and for all of these sorts of initiatives, because there are paths that have not been taken yet, and it's pretty exciting that we get to explore them and forge them all together. So I thank you for this, and I also am looking forward to chatting about this some more in our coming conversation.
Amazing. Thank you so much, Lia. This has been quite the project, especially with the complexities involved with bundling together two very separate technologies. But it's been an incredible experience, and we look forward, like you, to be able to share the results very soon, maybe at next year's OBI Power Hour, who knows. And last, but certainly not least, we have Shawn Paron, Chief Operating Officer of the Alzheimer Society of Ontario. She's going to be telling us about the latest Cortex initiative, which we are just in the process of launching. Shawn?
Thank you for having me. It's actually fascinating to follow both Catherine and Lia, knowing that you've both gone through projects that are either just completed or about to be completed. It gives me a lot of hope, and I look forward to the panel discussion. We are here today to talk about the project at the Alzheimer Society. But I want to give you a little bit of context first. And so I know that most who will be attending this will know obviously a little bit about dementia, but the context of Dementia in Ontario, because I'm at the Alzheimer Society of Ontario, is quite the picture, with over 315,000 Ontarians with dementia today. And by 2050, which quite frankly is not that far away, we're going to be at over 750,000 people living with dementia in Ontario. And that's just Ontario, so not Canada-wide. When we look at the caregivers that are impacted in that number, it's staggering. I know that the strong desire to get the ball moving when it comes to taking care of people living with dementia and getting them early diagnosis. And so I've had multiple conversations with Christa from the Ontario Brain Institute, who you've already met today. And in our conversations, we've talked about the gaps in the system. And this is a very simplistic way of looking at it. I understand the healthcare system is complex. But one of the things that we wanted to do was break it down into segments. And at the Alzheimer Society, we've looked at where we can intersect in the space of dementia and where we can make a difference. And so on the screen before you are some of the areas where we're looking at really taking a strong stance and intersecting. And for today's purposes, we'll be talking about early detection, dementia pathway or a lack thereof, diagnostic capacity, and of course, access to disease modifying therapies. There are 2 in the pipeline right now, and they are set, I believe, to be coming to Canada probably within the next 2 years, and we're not ready. And so we need to put an infrastructure around access. We need to create a better diagnostic pathway, and we need to partner to get that done. And we can do so using Neurotech. So we're doing at the Alzheimer Society of Ontario what we're calling a demonstration project, and we're labeling it a demonstration project for the purposes later on of government funding. So we want to be able to highlight that this project that I'm about to explain to you, one, has the potential to alleviate barriers on the healthcare system, to increase diagnostic capacity, to alleviate wait times, and probably a plethora of other things that we'll be able to help within the dementia space. The demonstration project is going to be spread across 6 communities in Ontario where clients are going to be screened with cognitive screening tools. We've partnered with MOCA and the Ontario Brain Institute to do a process very similar to what Catherine highlighted in her slide. I think it was called the overview of the study. And so, though we're not quite there yet because we're at the inception of our project, we anticipate that we'll have a slide just like that at the end of it to be able to highlight the workflow of clients coming into the Alzheimer Society, how they get screened all the way to where they get to a dementia registry. So what we're looking to do is primarily, number one, would be to screen out the worried well. And how we're going to do that is by partnering with MOCA, as I mentioned, to test their Neurotech, which is online devices or digital devices to be able to do a screening, a cognitive assessment. The MOCA Espresso is only 7 minutes, and it's really there to triage folks who are having a bad day, folks who really want to make sure that they're okay, but probably don't need a full cognitive assessment. So by doing that, we're looking to not only alleviate their concerns, but also alleviate the wait times that are happening at primary care and at local societies who are already doing cognitive assessments. If it's not a worried well situation, then they end up progressing on to a proper cognitive assessment where we're going to be utilizing 3 different validated screening tools. We've got the MMSC or the SICA and then the MOCA as well. And so 6 local societies of the Alzheimer Society have stepped up and will be doing those assessments to be able to then send people to primary care if they need it. The idea here is that 1, we're intersecting hopefully early in their dementia journey. 2, we're able to send them and refer them back to primary care to get a confirmatory diagnosis, and hopefully that doesn't take too long. But 2, if you're already intersecting with the Alzheimer Society, then we'll be able to provide you supports immediately. So refer you to education, to programs and services that we offer so that it's a wraparound support built within the community. Now, that was a really cool part, but really cool is the dementia registry that we're building with OBI. And OBI, the Ontario Brain Institute, has really taken the lead on this, obviously, with their informatics platform. But we will be creating a real-world evidence dementia registry in Canada. So we're starting in Ontario. The data that we'll be collecting will be able to be used later on to help inform policy, to help best practices of what we're doing in the community, to help with disease modifying therapies, to monitor the progression of disease. The opportunities with this are endless, as we've seen with other disease registries. Ideally, if we get ahead of the game, we're already behind. If we get ahead, when a disease modifying therapy comes to Ontario, people will have access because they will have a cognitive assessment, they will be in the registry, and hopefully a confirmatory diagnosis. We're working very hard to get the project up and running. And partnerships. So partnerships, I think, are probably the most crucial component to all that we're doing here. So not only, it can't just be the Alzheimer Society, we're one organization. And as mentioned in the previous presentations, look at all the amazing things that are happening across the province right now that in theory, we could intersect. So imagine if we had Retispec, so folks across Ontario could get their eyes checked and then were referred to get a cognitive assessment at the Alzheimer Society. Or we partnered with Lia and her team to have the AI be able to monitor and see how they're doing. And if they needed somebody because they were in that rural community, now they can reach out to the Alzheimer Society, or we could have already intersected. So partnerships are really the key to success, in my opinion. The key partners highlighted on the screen there are the Ontario Brain Institute, MOCA, and the Alzheimer Societies in Ontario. But I really believe that, as I just mentioned, across the sector, people are really doing amazing things. And I think that if we sat down and looked at what each place is doing, there are probably areas where we could intersect quite easily and make a difference in the dementia care pathway, which really doesn't exist right now. And I think it's up to us in the community, with government and with funders, to build it. And so that's what we're doing. I hope that when let me stop sharing here, but I hope that next time you present, we can I can present our findings and have amazing validation, and hopefully can actually say that along the way we built new and different partnerships, because this is something that we want to spread and scale across Ontario and ultimately across Canada. So I'm excited to be here and looking forward to the discussion on the panel.
Amazing. Thank you, Shawn. I have to say, this project in particular has been so much fun to co-create with you. It really is a testament to each of us bringing our unique strengths and skill sets to the table to really build out something that's going to be pretty incredible, I think, and you think, and it's just so exciting. So I look forward to being able to report back on this. One small point of clarification, just in case there's any regulatory bodies sitting in the audience. So stage one is the espresso is going to be compared to the MOCA, MMSE, and the SICA to see how it actually does perform before we can start using that as a screening tool more broadly.
Yes. You're right. That'll be done in the first year, where we're validating the tool so that ideally we'll be able to screen out the worried. Absolutely.
All right. So now we get to move on to the panel. Are we ready, ladies? You all know me really well, so this won't come as a surprise to you, but I'm really bad at sticking to scripts. We've already seen that so far in this panel. So I know we talked a little bit about some of the questions we might go through today, but just be ready. I promise it's a safe space. We're all friends here. First of all, I want to toss it to Catherine and Lia to maybe highlight if any of the findings that came out of your two projects, especially as it relates to the seniors experience, that really surprised you. And I know you touched on it a little bit in your presentations, but maybe Catherine, you could kick us off.
Sure, yeah, thank you. So certainly tons of lessons learned throughout our project. I think there were three that really stuck with me. So the first has to do with how the system currently works. And so I'll say I was really honestly surprised by how many participants described not having their memory concerns taken seriously when they raised the flag with their primary care provider. And this is not to disparage primary care providers. I think we have excellent providers here in Ontario, but there is clearly a gap in the capacity to address these concerns in a meaningful way. And this is particularly salient when I think about the second thing that surprised me is that we actually had 42% of our participants, of the folks that we screened, receive a dementia-related diagnosis as a result of taking part in this study. So, I think we were finding quite a significant proportion of people had very legitimate reasons to be concerned. On the flip side of that, we also had a couple cases where folks did have a memory concern and had real symptoms there, but they weren't related to dementia. They were actually attributable to a hormone imbalance in some cases. And so just participating in the screening allowed those things to be addressed and resolved in a very timely manner. And then sort of the worries were able to be relieved. And so I think there's value, regardless of the outcome, in understanding what might be causing that memory concern. And sort of accessible community-based screening programs can be really, really critical to helping people get those answers in a timely way in the communities with which they live. I think the third thing that was a bit surprising to me was the amount of people who actually wanted to know their results. So sometimes we hear from folks, they don't want to know, or people don't actually care. There's nothing they can do about it. We know that that's absolutely not the case. There's lots of things that can be done today and in hopefully a very short time horizon that will also include disease modifying therapies here in Canada. But we actually, because we asked folks this in the survey, and 100% of people wanted to know their results or have them sent to their doctor. So I think, we need to trust people and allow access to this information in a timely way, because the data are showing that there's a very, very strong demand to have that information. So yeah.
I kind of love that you ended with that being an element of surprise, because in our experience here, once people, when we send out recruitment calls and they sort of agree they want to be part of a study, they always want to know everything about how they did after every session, after the end of it. So one of the things I was going to share, two things. One that I was going to say was that we did not observe what some may have anticipated was a bit of a fear of AI driven technologies. Right? That's a really common sentiment that a lot of people kind of assume, particularly they may make stereotypes about older adults, thinking that they may be more likely to be hesitant with respect to giving their likeness and audio quality to the unknown artificially intelligent overlords. But we had a lot of interest in this project, even knowing that that's exactly what was happening, which was a pleasant surprise. And as soon as they decided they bought in and they're into this technology notion, they were fully into it, which I kind of like, because I think from an uptake and an implementation perspective is once you make the case for folks about what's the value of you engaging with this screening tool, this character, this whatever it is, right? You can more clearly draw the link to them to why is this beneficial? Why should you keep doing it? Why should you make sure you go back to the optometrist, do that MOCA again, right? I think that's a really good takeaway for me. And the other surprising thing I referenced in my presentation was how people were considering how tailoring the virtual character might impact the way that they engage with it. So I admittedly hadn't really thought about that in too much detail, because I think a lot of times these characters are meant to be quasi-neutral. A lot of them are a little bit androgynous intentionally, because they sort of just say, well, let's just try to find as central a ground as possible. But people here were really volunteering, like, if it looked like I was chatting to, my sister, I would tell her way more things than I would otherwise. Or if it, there was some kind of kinship that they were to form. No, even knowing it's an artificial character and it's an artificial relationship, the value of that in thinking around how do we get people to make use of these technologies was a really interesting and fun surprise for me.
And Lia, one of the learnings that you shared with me offline, what related to the speed of speech, and how participants were very aware of their slowed speech and felt more comfortable speaking with a digital human as well, which I thought was incredible. So you might actually get a more assessment.
Exactly. So you get into that, you lose the perceptions of being judged or being hurried or being rushed out of a clinic, which a lot of people will report when they're in. And again, amazing primary care, amazing clinicians out there, but time is time and folks are busy, right? And so this eliminated that particular barrier or sentiment for a lot of participants.
Amazing. Thank you. All right, I'm going to turn it over to Shawn now. Shawn, we're just starting this journey together with the dementia registry and the tech testing. You heard Catherine and Lia give their incredible presentations and some of their key takeaways. What are some of the things that you heard from their presentations that you want to make sure that we embed into the dementia registry?
Yeah, so a couple of things. I made some notes, and I think being able to see the lessons learned after you've been through it, I think it's important then when starting any project, we look at what's been done before and how can we take what you've done and not make the same mistakes if you've made any, or build upon what you've already created, right? So I think something we've already known, but it's just solidified and reinforced here, is that you have to have people living with dementia part of the process. Not necessarily will they be on the back end building the dementia registry with us. However, the actual process from they get to the Alzheimer Society, what's the process once they're here with us, how are they getting to primary care, the types of questions that we're asking. It's crucial that people living with dementia as well as their care partners are involved in the process. I think also having a health equity, looking at ensuring that we reach all Ontarians who need it. And that means that I think what you mentioned, Lia, with AI is a really good example that people feel more comfortable when they're around people who are like them, especially when it comes to, I was in a call the other day talking about a nurse taking blood from them. If you're somebody with dementia, you might want somebody who looks like you to be a little bit calmer. So I think it's really crucial, one, to look at the representation we have across Ontario and ensuring that we're meeting the needs of all Ontarians. And that means that, well, at the Alzheimer Society of Ontario, we're building a health equity framework. And we're at the beginning. We've got awesome people here doing great things. But I think that also means that not only do we need people living with dementia to be part of it, but also people from different communities to be part of the discussion to build it properly so that we meet the needs of all. And then I also think being able to have partners like this on this panel to be able to reach out afterwards. So if I have a question, I can say, hey, Catherine or Lia, I have this thought from the thing that you said. Can we connect? And I think that partnerships, I know I said it earlier, but that's the thing. That's the key that's going to move the needle forward for people living with dementia. It's us working together and having the openness to be able to do so, I think, is crucial, which everybody on this panel has already shown that they do exponentially well. So
I might have something to do with why we selected the three of you to be part of this panel. But anyways, I think the other piece that I want to just riff off of that Shawn was just saying, even as part of the evaluation framework for the dementia registry and the cognitive testing, it's not just about looking at who comes through the door, but also trying to understand who's not coming through the door and why, and how do we then learn from that and look at being able to deploy and tweak and rethink how we're delivering some of these supports. Okay.
Can I add just very quickly?
Yeah.
The last thing on that is not only that, but looking and taking a nimble approach to be able to say, like, I didn't know about Lia's project beforehand. So maybe our project morphs because Lia has validated data later on, and 3 years from now, we might be able to incorporate you in, which shifts a little bit of how we're collecting data for the registry. That's it. I'm excited.
100%. And there was another selfish reason why I brought the three of you together, because certainly there are opportunities here, and the intersections between all of the technologies and the partners is just incredible. I'm super excited to see where we can take this. All right, Lia. The center focuses on testing tech with seniors. And as we think about how we bring in additional technologies to test perhaps in the context of the dementia registry and more broadly, what are some of the key criteria that you look for when you're selecting technology?
That's a great question. So I think part of it certainly is a level of innovation. I mean, there's a lot of things out there that, for a little while, I think I had one reminiscence app per week reaching out for me, asking for evaluation, right? And in the beginning, that was innovative. 2 years on, it was not so much anymore. So a little bit is, how are, kind of almost a little bit to Shawn's point, like how are people making advantage and looking at what has already been done and changing it based on what we now know about the world. So for example, in today's current climate, everyone's in a post-pandemic space where the notion that I can do 99% of everything I need to do remotely still holds true. We're doing it remotely. We're in 4 different places. So folks who then are told, well, you must be here at this time to do this thing because this is the only way it's possible, that's a much harder ask now. And that's now a barrier for recruitment, particularly when it's not something clinical that they would already have to do. Right, so going to the optometrist, you were already going to go to the optometrist, much easier and makes way more sense to integrate something into an existing practice than have to tell people they need to create a new one. So when I say innovative in the technologies, it's people who are thinking about what the world is like now and what people are feeling about now, and that's part of their framing of the technology. The technology is a tool. It can be as sophisticated and magical in its analytic capacity as you want it to be. But it only makes any sense if it fits into the toolkit that this particular person needs to make use of. So really for me, it's kind of the like, yeah, but why? Who cares? Kinds of questions that I really look to evaluate. I'm not the one who's necessarily judging whether, your coding is efficient and eloquent. And, that's not my role in this particular equation. I'm really thinking about, this is the real world. This is where you want to toss this out into and see how it performs. So for me, the questions that I ask of the companies really relate to the logistics, the troubleshooting, what level of troubleshooting capacity does the user require, right? And, lots of people are very tech savvy these days, but it depends on what level you require of them in a day-to-day capacity and how much does this interfere with their daily lives. So those are really my questions about, how do you want this to act? And a lot of technologies, I will say, and the companies have not quite thought that through. And they're sometimes a little surprised when we may push back or offer some constructive criticism that says, well, people really didn't like having to put this on. Like, oh, but that's okay, they'll be fine. I'm like, no, they won't. They won't use it. So I think also maybe a willingness to integrate the findings from the project. If you're coming in assuming you know the answer, then you probably won't enjoy the process of engaging in the study.
Amazing. I'm seeing a lot of nodding heads. This is great. Okay, so we are going to go back to something I put in a pin in earlier. And this is, again, a question for Catherine and Lia. The response rate and the engagement from the seniors for both the Retispec project and the Sheridan studies was really incredible. Again, you've hinted at this in some of the dialogue so far, but why do you think seniors were so keen to participate?
So I think this is a really great question. I think in reflecting on our project, it comes down to sort of who was providing the screening, how was it being provided, and just sort of what natural interest in information about your own body and your health. I think those are sort of the three hallmark things, and I'll just expand a little bit. In terms of who was providing it, so we had both the Retispec scan that was provided by optometry. And so this is where we had a trusted healthcare provider who's already looking into measures of brain health every single day and also has strong relationships with their patients. And so that was really, really important that you're having a conversation with somebody that you already know and trust. So that was really helpful. And on the cognitive assessment side, we were supported by the Alzheimer Society of Toronto. So these were trained social workers who had already been in practice for quite some time, but also underwent additional training in how to conduct cognitive assessments, do a focused medical history related to these assessments, and to support the clients through that process. And so these are already people who are very comfortable in this space, but they took that extra level to upskill and prepare themselves for this conversation. So I think making sure that the people who are conducting the screening or engaging with the individuals is really, really important. And I think, as to how it was provided, we focused very much on ensuring that this was as low burden as possible for people. So we met them where they were. And sometimes that meant that, for the social workers, that they would conduct screenings in hours outside of standard business hours, because that was what was convenient for the people who wanted to have the screening done. And so I think being mindful of what the user needs, what their requirements are, making sure they don't have to go somewhere far, that the locations that it's being done are accessible, both from a physical perspective, but also very private for the types of conversations that are going to be happening, or so that they can concentrate for the cognitive assessments, is really, really important. And in terms of flipping back to the optometry side, we just incorporated a screening question into folks' routine eye exams. So the optometrist just added an extra question about whether or not people had experienced a significant change in their memory over the last 12 months. And then if they answered yes to that, then they were invited to consider this study. And so I think making sure that things are integrated well, that it's not burdensome to the clinic, that you understand sort of how that regular workflow is, and you very much focus on making it user-friendly for both the person coming in for the assessment and the people providing it, is really, really helpful and really helped increase the uptake on both the sort of cognitive and Retispec sides. And then lastly, we touched on this previously, there's a very, very strong desire for people to have information, especially if you have a memory concern. Understanding what might be the underlying cause, to either alleviate those concerns, or if it is something more significant than a worried well scenario, then being able to be connected to next steps to help you navigate that, to understand where you're at from the assessment perspective, and to know how to connect to the next levels of care. So I think all of those things, and the opportunity to actually connect into care for people who hadn't been able to close the gap previously, I think was a really important factor that really sort of drove people to take part in this. So yeah, I think just sort of from the multifactorial perspective, those things were really, really helpful. Lia, I'll pass it to you now for any further insights.
Everything that you said resonates with, perhaps not this project in its entirety, but with ones that we've undertaken in the past. Everything that you said has resonated completely for me. I think the thing that I'll add, and it expands a bit on, the notion of wanting to know more and wanting to be engaged. I think that the experiences people had during the pandemic have perhaps opened their eyes to new ways of doing things. So new ways that things might be integrated into a regular course of care, or new platforms, opportunities where they could be receiving benefit of some kind, whether that benefit be, medical attention, clinical care, information, education, any of it, right? And I think that there's a little bit of perhaps in some people, there's a greater willingness now to explore some of these things than there may have been 4 years ago. At least that's something that we're observing, is we're seeing that people are now far more interested and open to the idea of trying new things than they may have been before. Things don't seem quite so foreign or different, perhaps, as they may have sounded a few years back. And I think that's representing a willingness and a desire in society to continue moving forward and see where all of these new technologies take us, which I think is personally is a great thing. I'm a fan of novel technologies and how we can, figure out why and how they can make our lives better without putting people at risk or without concerning people because of things like privacy and security. Those are really important. We need to figure them out. And the only way that we can figure them out is to test them in a variety of scenarios and find all those pain points. So I think the interest in the study, Christa, to your direct question, really stems from, people are recognizing, like, this is cool. This is the future. Let me try this. Let me engage in this. And a lot of members of our community are really interested in those questions. And I think that's really what drove the engagement, right? That they were willing to come to a place that was not part of the regular clinical routine to be involved in this year-long study. I think that's partly what it is. People are curious. They want to know.
And this is what fills me with hope for the project that we're doing with Shawn, because a lot of the work that we're going to be doing is actually starting in more rural communities where people don't necessarily have access to a lot of these things. Shawn, I know that you see the opportunity for Neurotech to help us defy dementia. How do we make sure that the tech is inclusive and accessible to all seniors, regardless of socioeconomic status, digital literacy, and geographic location?
Yeah, I think that absolutely has to be built into the plan. I think that one, as I mentioned earlier, learning from projects that have gone before us that have used neurotech with seniors, I think is important. I think having, like I said earlier, people with lived experience, people from rural communities, people from different socioeconomical backgrounds at the table to help us build it. We are not the subject matter experts on neurotech and seniors in a brand new way, right? So we're exploring together. And I think that it's just important to have folks at the table at the beginning and then be able to say, okay, that didn't work the way we thought it was going to, and course correct. And I think that having the people at the table at the beginning is going to set the stage for success, really. And then also being able to alter course as tech shifts and changes. As Lia said, what was relevant 2 years ago is no longer the same. And so we need to be able to shift our focus as well, and then go in the loop again of bringing people back to the table as tech changes.
Christa, can I chime in on that? Just because you will well know the many number of times that we had to alter course and change direction on our project based on technology fact. One day the virtual human didn't want to talk to anybody. So what do we do from a project coordination perspective? Someone says, "Oh, I'm actually in Florida. I can't come in next week." Well, what do we do, right? So a lot of what we try to positively reframe everything was, okay, what are we learning about implementation from this challenge, from this setback, right? And so, it's about being flexible within the course of it, but I think also trying to still capture those learnings, right? It was a failure of the intended process, but not necessarily a failure of a future potential process. And so we really tried hard to take every one of those setbacks and figure out, okay, well, what was the underlying cause for that? What would that mean from a long-term feasibility and scalability perspective? Can you do this from Florida? Yeah, 100%. Right? We just have to just plan it out that way and just be aware of it that way. So I actually wanted to chime in because I think that was just so relevant.
And I'm going to make a little
Can I say something too? I
Yeah.
have one more thought on that. The fail fast. I think that our sector needs to fail fast. I think if you're not failing, you're not trying. And that's how new and innovative things come to be. And so failure is never a bad thing. A misstep is never a bad thing if you're learning from it and shifting, because it's only going to make something that much better and more user friendly. So bring on the failures. Obviously ours is going to go great. As long as we're learning from it, I think that our sector really would, I think it would be good if we took that motto.
I'm going to turn it over to Catherine before I ask my last question, because I think I really want Catherine to share with us what's up next for Retispec, because you did this amazing project in the community. Optometry clinics are really interested. You're getting a lot of traction. So where do you go from here?
Yeah, it's a great question. So we have a really exciting next sort of 12 to 18 months ahead. This year we are preparing for our, it's called a pivotal study, and this is the one that we submit to Health Canada and FDA. And so we are preparing for that, which is very exciting, which means that early next year, if all goes well, and if Health Canada and FDA agree with the safety and efficacy of the data we present, that we may be focused on bringing this to the clinic. So this is a very, very exciting time for us. And I think it also really speaks to some of what we've been talking about here, about the value and importance of partnering and of failing fast, as Shawn said, because I think programs like this and the partnership that we have been fortunate to have between the Ontario Brain Institute, the Alzheimer Society of Ontario and Toronto in particular, along with CABI and others, have helped us to test this in the real world, to see what works, what doesn't, how do people talk about this, how do we deal with things that we didn't expect, because all of these opportunities will, I hope, lead to a much more successful implementation and adoption. And we're already continuing to iterate on this particular project at another site in Florida where we're learning even more things. So we're taking sort of what we gain from each project and continuing to iterate. And if we have minor failures, we're hoping to do those fast. But all of this means that we're better set for success when this technology is ready for prime time, which is really, really important. So just wanted to extend a note of gratitude and thanks for such exceptional partnerships that have allowed us to learn so much and to prepare in such an important way, because we can only really know when we do. And so I think it's really critical that Ontario Brain Institute and the Alzheimer Society of Ontario continue to have the opportunity to test these things in the real world and help prepare for an ecosystem where we have lots of options that meet people where they are, that are accessible, non-invasive, affordable, and can really help to close those care gaps. So I just couldn't be more grateful.
Amazing. And I'm just going to make my own little plug for you guys. It's an Ontario company. And when the time is right, we'll have a beautiful registry that hopefully will be up and fully scaled, and we'll have integration points into the healthcare system. So we really look forward to that. All right. Last question from me. Let's do a little bit more forward looking here. Can each of you share your vision for the future of dementia care, the role of community groups and neurotech? And maybe I'll ask Shawn to kick us off.
Sure. Quite excited about the future, and because of conversations like this. And I've seen a proposed dementia care pathway presented, and it's very linear in many ways. And I picture it more like a spider web, that we need to intersect with people, as Catherine just said, where they are. And so whether that's getting your eyes tested, who knows, blood-based biomarkers may become a thing in the next 5 years. So I think that we can provide wraparound supports for people where they are, and neurotech is going to be at the forefront of it. AI is changing rapidly day by day. So I can't even imagine 1 year from now what AI is going to be doing to be able to support people living with dementia. But I would love to see, specifically in Ontario, a more formalized partnership of people who work in the dementia space. And that would mean not only from a fundraising perspective, awareness, anti-stigma. I think we need to combat stigma immediately to be able to have people comfortable enough to go and see their primary care. But I think we need to be able to do it together. And I think conversations like this are amazing. I think a more formalized committee or something would be the way forward, in my opinion, to be able to get us to where we need to be, and then ensuring that neurotech is at all of our tables and conversations, because that is the way forward.
Amazing. Catherine, do you want to go next?
Sure. So, for the future of dementia care and sort of where I'd love to see things moving, I think continuing to lean into opportunities for early detection and follow on care to make sure that we're not missing folks is absolutely essential. We know that Canada as a whole is a very expansive and diverse country, and we see that emphasized here in Ontario, both in terms of geography and just the diversity of people that live here in this province and require early detection and care. So I think that leveraging the wide range of tools that are available will be really, really important, especially for rural and remote regions where facilitating timely diagnosis is particularly challenging. So leaning into some of the tools that require basically Wi-Fi and electricity may be really, really helpful. And so I think we're on the cusp of being able to roll out some really exciting opportunities, but we need to also make sure that we're connecting, sort of not stopping at the detection phase, but making sure that we have comprehensive care plans for folks so that we don't lose them along the way. And since we are hopefully on the cusp of disease-modifying therapies being available here in Ontario and in Canada, it's all the more urgent that we be prepared, because certainly there are countless families and care partners that will be looking for these options above and beyond who we're already seeing now.
Amazing. And Lia?
I second everything my esteemed co-panelists have said, and sort of picking up on where Catherine ended, I will share hats, my researcher hat as well as my personal human hat. Supporting 2 of 4 grandparents on their own dementia journeys, including moving my family into the home of one of them to support them because it was happening during the pandemic and there were no other supports available, and having to navigate that in an ultimate sandwich generation kind of a capacity as a caregiver and as a researcher all at the same time. So I think in addition to early detection, this continuous follow-up support and the wraparound care that's available, I think for me it's a little bit more of how do we integrate brain health and the benefits of tech and neurotech into our dialogues about overall health and well-being right from the very start. Right? We're always talking about nutrition. We're always talking about exercise. Let's have brain health be just the default part of that, right? So that it's something that we begin to understand and recognize from a far younger age than perhaps many folks do now, right? I'm mindful of it. It's already part of advanced care planning, right? And it's about the thought, it influences the decisions I make about where I live, the roles that I take, how, my transportation, my home modifications, so I think to me it's opening a door for this to be a bigger part of a bigger conversation. And the neurotech and all of these opportunities afford us more data with which to be making these informed decisions about our health and our evolving care needs, and having the conversations with the relevant clinicians, the relevant friends and family members, right? And planning for it a little bit better. Not that we can sort of plan away the effects of dementia by any stretch, right? But by acknowledging them and recognizing them and already having an understanding of what are the tools that we have at our disposal to investigate, address, treat, screen for all of these related conditions. I think to me it's about, this is the key that unlocks the door to a much broader conversation than we've been having to date. And a lot of groups do an excellent job of that, CABI, Baycrest, OBI, the Alzheimer Society. I mean, everyone. There's a lot of groups doing a lot of great work in that space. Let's have everyone have a much bigger, better conversation about it.
Amazing. Thank you. And just to pick that thread up as well, I think it's about giving people options and starting the conversation early so that we're talking about brain health and not just dementia, not only beginning that conversation once we're worried about dementia. And circling back to what Shawn was saying at the beginning, everybody's journey is going to be different. So how do we deploy this spider web through partnership and collaboration and understanding there are more than one solution? There's more than one solution out there. So how do we deploy those so that people can choose their own adventure or make their way through the spider web to get to where they need to be in terms of accessing the care that they want and need? All right, ladies, thank you. From the bottom of my heart, thank you. I knew this was going to be a lot of fun, and it really certainly did exceed my expectations. You guys are incredible partners, and we look forward to many more great things coming from your organizations to help us defy dementia. And to the audience, thank you for joining us for this year's OBI Power Hour. The panelists are happy to answer any questions that you have via the chat. You can also reach out to any of us via LinkedIn or send your questions to info@braininstitute.ca, and myself and my colleagues will direct your questions to the appropriate person. Thanks, everyone. Have a great day.